morning, everyone. I'm Dr. Bara Evangelista-Huber, and today we are going to do a one-on-one discussion on skin concerns. It's a bit of a challenging topic because it's so broad, but I also didn't want you to feel like you were just listening or reading a Wikipedia article. So hopefully this discussion is enlightening and fun, and you could learn something from me today. Let's start. There are so many skin concerns out there, and they can range from harmless to life threatening. They can be transient or lifelong. They can go skin deep or beyond. They can be aesthetic or medical in nature, and they can be simple to complicated. So, when it comes to diagnosing and treating skin conditions, I consider the following factors. What is the main structure of the skin affected? Is it the epidermis? Is it the stratum corneum? Is it the dermis? Is it both? I also want to understand the underlying etiopathogenesis. How did the disease evolve? Is this mainly because of an infectious agent? Is this an inflammatory condition? Is it a neoplastic condition? I also need to take into account the site of the lesion. Where is it in the body? How is it distributed? Is it left and right? Is it symmetric? And then you want to correlate this with available treatment options. What is the mechanism of action of the treatment you are considering, and how does that fit into the condition's etiopathogenesis? We'll talk about that more later. And lastly, of course, we do not forget our patient. We want to consider patient-related factors, such as age. Is the patient currently breastfeeding, pregnant? Are there certain medications that this patient cannot use or apply? So all of these must be considered when diagnosing and treating skin disorders. I decided to approach this lecture by sharing with you questions I ask myself as a dermatologist, as well as values that I live by. So first, don't miss the forest for the trees. Some skin concerns can really look quite similar, especially up close. And that's why photos aren't usually enough. We need to see the bigger picture, and we need to ask questions. For example, how did it start? How did the lesion evolve? Where is the site affected? We also want to look at the lesion characteristics like the size, shape, color, borders. Again, the distribution, is it symmetrical? All of these things matter. You also want to know if other parts of the body are affected. For example, the nails, the scalp, the hair, the mucous membranes. What other symptoms are present? Is there pain? Is there itch? Is there fever? What are the triggering or exacerbating factors? For example, is it heat? Is it exposure to UV radiation? Is it exposure to certain skincare ingredients? You also want to know the family history of the patient. Is a family history of eczema present, acne? Has the patient taken or applied any medications or cosmetics? And you also want to take into account if the patient has existing medical conditions. For example, polycystic ovarian syndrome if your patient has acne. It's very important to get the diagnosis right because that then dictates the treatment that you are going to give the patient. So let's look at these two cases. Both of them look like acne, right? But on the left side, this patient has actually been applying topical steroids for a long time. So her acne is steroid induced. On the right side, this is just your run-of-the-mill acne vulgaris. If you didn't catch that the patient was applying steroid medications on her face, you might not have been able to tell her to stop. And no matter what you do, even if you start acne medications, if the cause or the trigger for her acne is still there, it's not going to go away. That's why it's very important to ask questions related to your case. And here, we again have similar looking cases. They both look like dry skin. On the left photo, you could see that dryness is everywhere, including the lips. However, when you look on the right side, this photo shows accentuation of dryness and also redness here on the eyebrows, on the malar area. And this is actually seborrheic dermatitis. So dry skin can be managed by a good skincare routine. However, you might need more than just a good skincare routine if the patient has seborrheic dermatitis. We'll talk about that more later. Here you have similar looking lesions. You have reddish ring-like plaques on the body. So on the left side, this is actually psoriasis. On the right side, this is tinea corporis or dermatophytosis, a fungal infection. Psoriasis is best treated with anti-inflammatory agents like steroids. Tinea corporis, a superficial fungal infection, will benefit from antifungals. If tinea corporis was misdiagnosed as psoriasis and steroids were given to the patient with tinea corporis, it would make the lesions worse and the patient will not get better. That is why it's very important to get the diagnosis right. So next we have here two similar looking lesions. They're both located in a similar location. They both are hyperpigmented or they have a dark color. They're roundish in shape, but the left lesion is benign. This is a seborrheic keratosis. However, on the right side, this photo is of a skin cancer, specifically basal cell carcinoma. I won't be discussing further the difference in the management of benign and malignant lesions, but it's important to know at this point that if you miss a diagnosis of skin cancer, this will have ramifications on your patient. So again, it's really important to get the diagnosis right. So the next question that's helpful to ask ourselves is, what is the origin story? Or what is the etiopathogenesis of the condition? Is this due to a skin barrier dysfunction? Is this because of an infectious agent? Is an inflammatory process responsible? Or is this a neoplastic process, which can be a benign tumor or a malignant tumor? The reality is, a lot of skin conditions have a multifactorial etiopathogenesis, and you'll see more about that later. It's not always like a bacterial infection where you have an infectious agent, so you give an antibacterial agent, and that then solves the problem. In many cases, you need to address several factors in the etiopathogenesis, which is why you may have combination treatments. So let's take a look at acne. There are four things believed to contribute to the pathogenesis of acne. You have abnormal follicular hyperkeratinization, where you have sticky cells in the area of your hair follicle, which don't exfoliate the normal way. You also have an increase in sebum production, which is primarily controlled by hormones. You have the bacteria Cutibacterium acnes, and inflammation is also thought to contribute. So when you manage acne, you want to target different things in the pathway. For example, keratolytics and comedolytics address abnormal follicular hyperkeratinization, and these include your hydroxy acids and benzoyl peroxide. You also may consider agents that control your sebum production. And as I've mentioned, hormones are really the number one factor that impacts sebum production. So depending on the patient, you can start the patient on isotretinoin, an oral retinoid that impacts the oil or sebaceous glands, or hormonal therapy, such as oral contraceptive pills. Antibacterial agents that target Cutibacterium acnes, such as benzoyl peroxide, also have a role. And lastly, you can add anti-inflammatory agents so that you can address inflammation. One example of this is using intralesional injections on inflamed and cystic acne. Now let's look at atopic dermatitis. Atopic dermatitis is characterized by skin barrier dysfunction, gaps in the epidermal barrier. So this allows the bad stuff like irritants, microorganisms to penetrate easily, and it also allows water to escape. So that's why the skin is often dry. On top of that, there is also an immune hyperreactivity to everyday substances. So whatever penetrates through the skin barrier, those with atopic dermatitis have a very robust immune response against it. So that causes the skin to be inflamed, and that manifests as redness and scaliness. So managing atopic dermatitis should target both of these things in its etiopathogenesis. So you want to make sure that you use a gentle cleanser and frequently use moisturizers to ensure that you are supporting the skin barrier. On the other hand, if inflammation already exists, then you can bring in anti-inflammatory agents such as your topical steroids. You also want to limit exposure to potential triggers, and there are many. This includes insect bites, sweat, animal dander, pollen, and for some, skincare ingredients such as fragrance, certain preservatives, and dyes. Seborrheic dermatitis, which manifests as dandruff on the scalp, also has a multifactorial etiopathogenesis. It involves an overgrowth of a yeast called malassezia, a buildup of skin cells and sebum, inflammation, and disruptions of the skin barrier. That's why for patients with seborrheic dermatitis, their management may include antifungal agents, keratolytics like hydroxy acids, anti-inflammatory agents like topical steroids, and you also want to make sure that the skin barrier is supported. So it helps to use non-irritating products. Next question, where is the beef? What then do we need to target or reach so we can resolve the skin concern? Some skin concerns are located only in the skin, and you want to ask yourself, which part of the skin does it affect? Is it just the epidermis? Is it the dermis? Is it only the stratum corneum? Are there specific skin structures involved? For example, hair follicles or blood vessels, Or are there specific skin cells that are responsible for the condition? For example, melanocytes. On the other hand, there are also skin conditions that have systemic involvement. However, I won't touch on these conditions in this lecture. So let's look at these three cases. The uppermost photo is of a wart. So this is a viral infection restricted to the epidermis. So you only really need to get to the epidermis to remove this wart. It can be through topical products or procedures done at the clinic. The other photo shows a mole, which is primarily a proliferation of melanocytes in the skin. Melanocytes are found in the dermoepidermal junction, which is the lower part of the epidermis. Benign moles can involve the epidermis, the dermis, or both. We don't use topical products when addressing moles. Excision or surgical removal of the mole is recommended if the patient wants it removed. This way, we can also look at the mole under the microscope in case there is concern that it is not benign. And then on the last photo, you have photoaging, which manifests as wrinkles, pigmentary changes, sallowness, and dullness of the skin. This condition affects the skin, both epidermis and dermis, and it also goes beyond the skin. So combination therapy is best when it comes to photoaging, and we'll talk about that a bit more later. Next, it's time to choose your fighter. What will be your treatment of choice? Will it be a topical product, which can be a drug or a cosmetic? Or do you prefer systemic products, something that can go everywhere, such as an oral drug or an oral supplement? You can also consider in-office treatments, and this will be further discussed by Dr. Chan. Topical products are often adequate for these concerns. First, conditions that occur in the superficial skin, particularly those in the stratum corneum. Conditions that affect only small areas of the body. Examples of these conditions include texture concerns, dehydrated or dry skin, mild cases of acne, mild cases of eczema, and superficial pigmentation. The choice between a topical drug and a topical cosmetic often depends on the severity of the condition. If the case is not mild, more widespread, or already has been refractory to topical cosmetics, it's probably time to see a dermatologist and use a topical drug. On the other hand, topicals are often inadequate for these conditions. Conditions that affect the deeper skin layers and beyond, widespread involvement, cases that already have been refractory to topical therapy, and those with underlying medical conditions. For example, in adult female patients with acne with underlying polycystic ovarian syndrome, it is best for the polycystic ovarian syndrome to be addressed by a gynecologist. In these cases, acne is just a manifestation of an underlying medical condition, so the medical condition must be treated first. And more often than not, this requires oral drugs targeting the underlying condition. Some examples of specific skin conditions that will probably need more than just topicals include moderate to severe acne, acne scars, extensive eczema, widespread infection, resistant melasma, and deep wrinkles and pigmentation. Next, now that you understand the origin story, you know where the beef is, and you've chosen your weapon of choice, it's time to attack on all sides. And this is particularly true for skin concerns that have a multifactorial etiology. I'm going to use melasma as an example. So it is believed that overexposure to ultraviolet light, hormones, genetic factors, and potentially visible and infrared light contribute to the etiopathogenesis of melasma. These factors tell the melanocyte to produce more melanin, and then transfers this to the skin cells called keratinocytes. And these keratinocytes become pigmented, and that's what you see in this photo. So why is melasma very difficult to treat? And it tends to be recurrent despite all our best efforts. It's because so many factors are involved in this condition. As I've mentioned, melanocytes and keratinocytes, which are the main skin cells. However, not just these two. Other cells like mast cells or fibroblasts are also thought to be involved. Recent studies have also shown that there is neoangiogenesis, meaning the production of new blood vessels. Inflammation and oxidative stress also contribute. The skin barrier is also thought to be impaired in patients with melasma. So as you can see, because so many factors are involved, it would be best to attack on all sides. So these are some of the pillars of treatment when it comes to melasma. The first is to prevent triggers. Most important here is sun avoidance and photoprotection. As I've mentioned, hormones contribute to melasma. So if the patient is taking oral contraceptive pills, it would be good to inform this patient that this might be contributing to the melasma. Melasma treatments can be melanocyte-centered or non-melanocyte-centered. Some melanocyte-centered treatments inhibit the production of melanin. Others inhibit the transfer of melanin from melanocytes to keratinocytes. On the other hand, you have several options for non-melanocyte-centered treatments. These include exfoliation of pigmented keratinocytes, anti-inflammatory and antioxidant agents, targeting blood vessels, targeting other skin cells like the mast cells, and making sure that the skin barrier is restored and supported. So this slide shows you the various melasma treatment options and what they address in the etiopathogenesis of melasma. As you can see, combination therapy is best because it combines different mechanisms of action to lead to better melasma control. Now, going back to skin aging is also multifactorial. I'm not even including here the changes beyond the skin. One of the changes is a reduced skin turnover, meaning your skin doesn't renew itself as quickly as it did when you were younger. There's also a reduction in skin sebum. That's why the skin can be prone to dryness as you age. There can also be an increase in pigmentation, especially in those with darker skin tones. There is a reduction or impairment in the structural components of the skin, such as collagen and elastin, and this can lead to wrinkles, sagging, and there's also increased oxidative stress, and this is why combination therapy is best for skin aging so that you can attack on all sides. So retinoids and keratolytics can increase skin turnover. You can use moisturizing products and ingredients to address the dryness, depigmenting agents like I've mentioned a while ago during the melasma topic, and sunscreens help with pigmentation. Retinoids and in-office procedures will also help address the issues with the structural components of the skin. Living a healthy lifestyle, increasing your antioxidant intake via your diet, or using topical antioxidants can also address the increase in oxidative stress. Now we're almost done. Always remember, when you're choosing your weapons, make sure that you select the heroes over the sidekicks. You always begin with the first-line treatments. And these are agents that have been consistently shown in clinical trials to be beneficial to this skin condition. Once you don't have good response to the first-line agents, you can replace or add on to the first-line treatments with the second-line treatments. And then if that doesn't work either, you can go up to the third line. So as you can see, for melasma, the first and second-line agents are mainly topical. In-office treatments and systemic agents are just considered third line. So now let's look at acne. The treatment of acne really depends on the severity of the acne. So this table is the acne treatment guidelines of the American Academy of Dermatology. And as you can see, it is stratified depending on the severity. So for mild cases, topical products are often enough. However, for moderate to severe cases, these acne patients need a bit more help and often benefit from systemic agents and in-office procedures. And now we're down to the last value to live by, and it is same, but different. It's important to remember that skin concerns can manifest differently in skin of color. So here you can see seborrheic dermatitis manifesting differently in a patient with a darker skin tone versus a patient with a lighter skin tone. So as you can see, you can miss the diagnosis if you are not aware that it can look different in these individuals. So here we have psoriasis, again, in two different skin tones. Similar to the other slide, you don't really see a red scaly rash in the patient with a darker skin tone. The lesions look more whitish and grayish versus red. Again, if you're not aware of this difference, you might miss the diagnosis. And lastly, melanoma. Melanoma appears in different areas in those with darker skin tones. For example, non-sun exposed sites, like you can see here in the photo. This may lead to a later diagnosis of melanoma in these patients. That is why it's really important to understand how skin concerns or skin conditions can manifest differently in patients with skin of color. Okay, so now I am down to my last two slides. When then should you see a dermatologist? If you have a skin condition that isn't responding to cosmetics and OTC drugs. If you think you will benefit from in-office procedures. If you have a persistent or recurrent rash. If you have a skin lesion or a wound that isn't healing. If you have a new spot or mole on your skin, a spot that looks different than all of your others, or a mole that has changed size, shape, or color. You can also see a dermatologist if you need something in your skin removed. If you have a hair or nail condition, remember we don't only treat skin conditions. If you have a skin, hair, or nail condition that is rapidly progressing, or a stable condition that is currently in flare. And lastly, if you are in doubt. And that's it. Thank you so much for listening to me today. And I hope you have learned from this lecture on skin concerns. Bye.